Welcome to PowerPoint number 3. We are still in chapter 4, and this chapter and this PowerPoint is going to be the development of the patient record. So let's go ahead. We're going to start off with inpatient record. It may actually begin prior to admission. So any pre-admission testing that you have to go to the hospital before you're admitted. It also patient registration, they get that all taken care of before you get admitted. Testing and other services usually are into one visit prior to your admission. This will include a chest x-ray, possibly EKG, laboratory testing, and other ancillary services. Keep in mind that this is if you have a scheduled inpatient admission coming up. Okay, so let's go from admission to discharge. Once again, we are talking inpatient. So it's generated in the facility's admissions office unless you are admitted through the ER. They'll take your demographic data, it's documented on the face sheet, or the admission screen of an electronic patient record. We will also have at this point a provisional diagnosis. This is what possibly the doctor thinks is wrong with the patient. A patient or patient representative, the person who has legal responsibility for the patient, signs an admission consent to treatment. HIPAA no longer requires healthcare facilities to obtain a consent for admission. Most facilities do it anyway. Admission, now we're done with admission and now we're going to the nursing unit. So admission information is reviewed with the patient and a nursing assessment is completed. At this point, your assessment documents your history, any current medications, the vital signs, and these all come on a variety of different nursing forms. And then your attending physician, whoever is the physician admitting you, performs a history and physical examination. The physician then will document different progress notes as you're there. If you have surgery, an operative report will go into your chart. And then ancillary department. Again, we have many different ancillary departments. When we're talking ancillary, we're talking lab, radiology, possibly any type of therapy. If there's physical therapy, occupational therapy, social services, those are all considered ancillary. Discharge the patient from the facility, and then a discharge summary at that point is generated. Okay, let's talk about date order of patient record reports. All reports documented in the patient record must be organized during inpatient hospitalization and upon discharge. So we're going to talk about reverse chronological date order during hospitalization. They reverse the order to chronological date upon discharge of the patient. So as a patient is in the hospital, the doctor wants reverse chronological order. And this makes sense because the doctor's coming in, they want to see what happened today. And if they want to look further, they'll look behind and see what happened the days before. Okay, so when a patient gets discharged, then they put everything in chronological order so that way it reads like a diary. So if you have a new doctor looking at this admission, they can read from the first day that they were admitted to when they got discharged. So that's chronological order is like a diary. Reverse chronological order is when they are actually an inpatient. Again, this explains it a little bit more. Reverse, the most current documents filed first, and then discharge patient records are typically, again, organized date order. The oldest information filed first. The order of reports is in strict order, and again, once I state it, it's like a diary. Universal chart order. Facilities organize reports in the same order for both inpatient and also discharge patient records. So again, they just do it the same. They don't do the reverse versus chronological. It saves time. They don't have to have somebody switching things around. And again, this way they don't have to reorganize reports. Keep in mind, if we're doing electronic health record, this isn't going to be a big deal because you're going to be pulling up reports pretty much in date entry as you see them. So you're going to be pulling up the app report. You'll be clicking on the history and physical. Progress notes will be in chronological. Okay, so a physician office record. Okay, now we're talking outpatient. Okay, so I get out of the hospital and now I'm going to the physician office possibly for a checkup. The main purpose of the physician office record is to provide documentation. Again, we want to assist in the continuity of patient care, and we want the development of the office record. It's going to vary. Office records for solo practitioners are typically not as structured as records created for group practices. So if you have one or two doctors versus a huge practice, possibly medical associates, they would have over 200 to 300 physicians practicing. Same thing if you get up to Gunderson, they have, again, a lot of physicians practicing. Patient record formats. Many facility and physicians maintain patient records in a paper format known as manual. And we're going to talk about the different types. We have source, problem-oriented, and integrated. Electronic records, these are automated records including your EHR, EMR, and optical disc imaging. There is something out there called mHealth. This refers to the use of wireless technology which enables healthcare professionals to make better quality decisions while reducing the cost of care and then improving convenience to caregivers. So again, it all goes with everything being wireless. They can hook right up, document right into that medical record right away. Primary sources of information. Okay, we're going to talk about primary and we're going to talk about secondary. Primary are records that document patient care provided by healthcare professionals. They're considered primary sources. So the original patient record, any x-rays, scans, EKGs, any other documents of clinical finding is primary. Now your secondary sources, these are patient information that contains data abstracted from primary sources of information. So let's go here. We have index registers, committee minutes, incident reports. So if I am I need to know if I'm doing committee minutes and I want to report how many were admitted for the month of June, I'm going to take the information from the primary source, the patient record, and I'm going to be able to get that information and put it in the committee minutes, which that's going to be my secondary source. Now for index and registers, if I have a register for cancer registry and I want to know how many were admitted for breast cancer in the last quarter, I am going to look at the codes, look through the records, and be able to pull again information out from the medical record and put it into the cancer register, which would be a secondary sources. And then incident reports, this would be something that happened. We'll get more into those. Okay, so what they are, anything that's a potentially compensable event. It's an accident or medical error that results in a personal injury or loss of property. They provide a summary of the incident, and these are never ever filed in the patient records. They're going to be somewhere in administration. Okay, one thing with different incident reports. Okay, let's say that's why people put out the signs, slippery when wet. Okay, so let's say you have somebody that slips. You're going to write up an incident report that so-and-so slipped in this hallway on this floor. Or let's say the bed rails weren't put up on a bed and a patient falls out of bed. That's an incident report that needs to be again filed. When an incident occurs, document the facts in the progress notes. Do not enter a note in the patient record that an incident report has been completed. You're just going to document the fact. Patient fell out of bed. Okay. Do not refer to the incident report when charting in the patient record. Again, you're going to talk about the accident, but not about the actual incident report. Okay, then we move on to the different types of records. Let's start off with source-oriented record. This is a traditional patient record format known as source-oriented. It maintains report according to the source of documentation. All documents generated by the nursing staff, they're located in the nursing section. This way it's easy to locate the documents. We'll have a lab section, we'll have a radiology section, we'll have a nursing section, and then at the back of the chart there's usually a correspondence section. The beginning of the chart usually could be progress notes, any hospital, they'll put hospital documents together. The disadvantage of a source is that if a physician wants to locate all the information on a diagnosis, they would have to pull from each different section. This can be very consuming and confusing. It's also known as a sectionalized record, and you're going to see this type of record more in an office setting. Now the POMR, Problem-Oriented Medical Record, this is to improve organization of the patient record. It's a more systematic method of documentation. It has 4 components. We have a database, the problem list, which is usually right at the beginning of the chart, initial plan, and then of course your progress notes. Your database is a minimum set of data that needs to be collected on every patient, such as we need to know their chief complaint. What is the diagnosis? We need to have the history. We need to have an examination, all documented. Where the problem list is going to be, once again, at the beginning of the chart, table of contents, and it's going to tell you different things that the patient had maybe in the past history or currently has. Initial plan is a strategy for management of the patient condition to treat and educate the patient. You're going to treat it according to diagnostic management plan, therapeutic, patient education. SOAP notes. Let's remember this. SOAP notes are in the POMR record. Okay? Each patient is assigned 1 or more problems, and notes are documented for each problem using the SOAP structure. So let's spell out SOAP. We start off with the subject. This is the patient's statement about how they feel. So let's just say they're coming in, they're saying, you know what, I have a headache today. Okay, objective. These are observations about the patient, such as physical findings or lab or x-ray results. So here I do have the chest x-rays negative. But if I want to stick with the headache, I could say that the patient's eyes are dilated. Okay, that would be an observation of the doctor. Assessment. Okay, so if we're still going, this is the judgment, the diagnosis. This is the opinion, evaluation made by the healthcare provider. So the doctor would say the assessment's acute migraine. In the plan, let's go ahead, what's going to resolve this problem? Okay, patient to take Tylenol is needed for the pain. So again, the SOAP note, remember you have the subject, objective, assessment, and plan. Make sure you reread through those because you will have some assignments on this. And then you do have a discharge summary, which will be a transfer note if the patient is being transferred. Integrated record. This is something that a hospital is going to use more. Okay, so remember that source in the POMR is going to be more physician, where integrated is going to be more hospital. And what they do here is chronological date order. Okay, it can also be due in reverse. But again, this is how you can read how the patient's progressing, how they are doing. Everything's ordered. It's not section. It's all for that one admission. Then we have the cheddar. This is something, we have chief complaint, history, examinations, the same thing as objective, details, drugs. We have an assessment. And then the R is for return visit. When are they coming in again? The reason they use this format because it's very comprehensive. And then the last one is similar to the SOAP note. We have history, physical, impression, and plan. It is logical organization of patient information. So again, review these. If you have any questions, let me know.